So we discussed pulmonary valve stenosis, and now let's look in more details into the subvalvular obstructions.
Let's talk about subinfundibular and infundibular pulmonary stenosis. Here's a schematic image how the RVOT can look like with a normally opening pulmonary valve, but a problem at the subvalvular level. Here are some scenarios why you can have infundibular hypertrophy. This can be pulmonary stenosis, this can be pulmonary hypertension, and this can be patients with tetralogy of Fallot. So let's have a look at the next patient. All four images are from the same patient. On the left upper corner you can see an RV-focused four-chamber view with RV hypertrophy. And the same can be appreciated in the subcostal RV inflow-outflow, where you can see a hypertrophied right ventricular wall. Elena, can you show me the pulmonary valve in this patient? It's a bit difficult to see.
It looks like I can see valve leaflets at this level. They do not seem very much thickened, and it seems like the motion is more or less preserved. But what is interesting in this view, it seems like there is a thickening of the walls of the RVOT. And this is the area where the narrowing occurs.
And actually, when you look at the color Doppler flow, the turbulent flow starts clearly at the subvalvular level already, actually at the entrance into the RVOT. And this is a patient with infundibular RVOT. And when we look at the gradients across the RVOT, we can notice first that peak velocity is 4.1 meters and peak gradient is 67 millimeters of mercury. And secondly, you can clearly see that this is not a round signal, but actually there's a dagger-shaped signal of the continuous wave Doppler, which indicates a dynamic component of this stenosis. Let's look at another example. This is a subcostal RV inflow-outflow short axis view, and we can nicely see the tricuspid valve, and we can also nicely see the pulmonic valve, which is as thin cusps as it's opening normally. However, we do see at the entrance to the RVOT there's some narrowing in the 2D image, and when we apply color Doppler, we do see turbulent flow, which originates already at the ventricular level and not over the pulmonary valve. Now, when we measure continuous wave Doppler through the turbulent flow, we see that it's elevated flow with 4 meters per second at a peak gradient of 65 millimeters of mercury.
Matthias, what is the diagnosis here?
Well, this is a very interesting finding and an important diagnosis to make. Really, this patient has double-chambered right ventricle. So what is that? A double-chambered right ventricle is frequently associated with a VSD. And one theory is that the high-velocity blood flow that comes from the LVOT into the right ventricle really leads to a hypertrophy and then really to a muscle bundle that then narrows the right ventricle and really divides it into two chambers. And this will lead to an intraventricular pressure gradient from a high pressure chamber into a low pressure chamber and then through the pulmonary valve. You have the inlet high pressure and the outlet low pressure, and usually the VSD will lead into the high pressure chamber. Let's look at this next patient. This is a patient who has received a surgical VSD closure previously, and now we perform follow-up examinations. And here we can see in the parasternal short axis view, we can see a narrowing that occurs in systole in the RVOT. And here's the color Doppler flow, and you can see elevated blood flow in the region where you have the systolic narrowing. So this is another case of a double-chambered right ventricle in a patient who previously had a VSD.
Well, thank you very much, Matthias. I think it was a brilliant overview of the RVOT subvalvular stenosis and obstruction. And this is something to remember when we image the patients with congenital heart disease, because assessment of the RVOT obstruction is not something we used to do frequently when we image adult patients in our echocardiography service. And these pathologies which we showed you in this part are very important to remember. So it can be just focal RVOT hypertrophy, it can be a patient with double chamber right ventricle in the presence of the VSD, it can be patient with hypertrophic cardiomyopathy with right ventricle involvement. But also another important point, the RVOT obstruction can be dynamic.
And I remember this one patient that I was imaging. He was a 35-year-old patient. I was imaging a 4-chamber view, normal-sized right ventricle. But then, looking at the RVOT, there was dynamic outflow tract obstruction. And there was quite some tuberculation. And then looking back in his old images, I saw a very, very large right ventricle, but it was significantly hypertrophied. And in reality, this patient was meanwhile transplanted due to significant pulmonary hypertension. And the right heart fell together after the afterload fell because of transplantation. However, the right ventricle was still hypertrophied, and all the muscle bundles that were still present led to some degree of dynamic obstruction in the RVOT in this patient.
Well, this summarized the current part on the RVOT obstructions, and we look forward to seeing you in the next part, where we discuss supravalvular stenosis and assessment of prosthetic pulmonary valve.